taken that study, let's go forward to the next study, that is the PARAGLIDE HF study. This trial was released in 2023 and it basically was in patients of heart failure with mildly reduced or preserved ejection fraction, that is EF between 40 and 60%. And this trial showed that when sacubitril valsartan was initiated as compared to other therapy, it led to a reduction in the NT-proBNP levels, better overall hierarchical composite outcomes, which included time to cardiovascular death, number and timings of heart failure hospitalizations, and urgent heart failure visits to the clinics. And it led to reduced worsening of the renal functions. Now, this was also noted, larger reductions were seen when the ejection fraction was lower than 60%, so not with the totally normal ejection fractions. Now, there were two subgroup analyses of this which were released, and they answered two very specific questions. Now we have a group of patients who are with heart failure with a mildly reduced or preserved ejection fraction. Amongst those patients, question number one, when should we initiate sacubitril valsartan versus only valsartan? Should it be in hospital or out of hospital? And the outcomes were numerically in favor of starting this at any time, but it showed that it was better to start sacubitril valsartan to reduce the NT-proBNP levels, irrespective to whether you started in or out of hospital. It just showed a benefit over the valsartan subgroup. Now, what this measured is something called a win ratio, where it showed that these patients, rather than measuring, so what happens in these trials is if a patient had a death or a hospitalization, that was an endpoint to their trial. They were not followed up further to see if the patient had worsening or not. So for example, if a patient had a heart failure hospitalization, went home and then died after 2 days, he was marked as a heart failure hospitalization, but not as a CV death, because that was the endpoint of his trial. So this win ratios measured more outcomes, not just deaths, but also deaths, hospitalization, urgent visits, and the change in BNP. And it did show that sacubitril valsartan provided benefits in or out of hospital, but as long as in the subset of heart failure with mildly reduced or preserved ejection fraction. So this was very clear message that it helps to start the combination as compared to valsartan and as early as possible. The second question is, what if it is a new heart failure patient versus a chronic heart failure patient who has worsened? And this was the second subgroup in the same category. And it also showed similar results that de novo and worsening chronic heart failure patients, they see larger reductions in NT-proBNP when the combination is started as compared to valsartan alone. So irrespective of in or out of hospital and irrespective of first diagnosis, that is de novo or chronic heart failure, the group of ARNI is more favorable in terms of NT-proBNP reduction in this subset. Now, this is important because we all know that the heart failure preserved ejection fraction group does not have any great outcomes in terms of a particular group of, it doesn't have these 4 pillars like the reduced heart failure patients do have.